Good afternoon, everyone. My name is Jamie Kitt. I'm a cardiologist and general internal medicine physician in Oxford and in Royal Berks in Reading, and a postdoctoral research fellow within the Radcliffe Department of Medicine at Oxford University. I spent my time in my PhD looking after women who had hypertensive disorders of pregnancy in the postpartum period, and that's one of the reasons I've been asked to come and talk to you today about prescribing in this period. So without further ado, I will turn my camera off and I will take you through the talk. I'm hoping to be available on the day to do question and answers after, but I'm actually presenting some of the POP-HT results at the British and Irish Hypertensive Society at the same day as this talk is scheduled, and hence the advance recording. So a little bit of background. Why are we talking about this particular condition? Hypertensive disorders of pregnancy are incredibly common. They affect 10% of women worldwide and more than 10% for those who are African or Caribbean. Both hypertensive disorders of pregnancy, i.e. preeclampsia, and gestational hypertension have significant impacts on the mum and the baby, but we're going to focus on mums today, during the birth, around the time of delivery, postpartum and longer term. A third of women affected will represent with chronic hypertension within 10 years. There's also a significant increase in the risk of cardiovascular disease, which I'll touch on the next slide, in the long term. In 2019, Lucy Chappell and the team that wrote the NICE guidelines tried to provide clarity on what these risks were so that women could be empowered and informed to do something about them, and also to try and help healthcare professionals like us guide treatment. It's a very evidence-based zone, and they took a brave step in making some of the recommendations, which we'll talk about today. So quite a busy slide here, but I guess the take-home messages are, hypertensive disorders of pregnancy don't only cause hypertension. There's almost doubling in the risk of coronary artery disease and heart failure, a more than twofold increase in the risk of aortic stenosis, and a fivefold increase in the risk of mitral regurgitation, the latter of which we're still trying to understand the mechanisms for, but we think it's due to hypertension and remodeling of the heart. The NICE guidelines on the right-hand box also try to quantify the risks, and as you can see, preeclampsia carries a threefold increase in the risk of a major adverse cardiovascular event, which includes heart attack, stroke, and death. Gestational hypertension, almost a doubling. There's a 2 to 3-fold increase in the risk of stroke for both, and as I touched upon on the last slide, a big increase in the risk of hypertension. So today's focus is about how to prescribe for hypertensive disorders of pregnancy. I'm not going to spend a lot of time talking about antenatal treatment, but I will just recap a few of the key messages from the NICE NG 133 guidelines. So in early pregnancy, for those who've got chronic or essential hypertension, i.e. they've been diagnosed with a blood pressure issue before they became pregnant and were already established on treatment, it's important we have them on the right drugs so that they're safe for the pregnancy, for the fetus. That includes stopping ACE inhibitors like ramipril and ARBs like canazatin and losartan within 2 days of confirmation of their pregnancy. Thiazide-like diuretics such as benzoyl-flumothiazide and dapamide should be avoided due to the risk of congenital abnormalities, and similarly, spironolactone and eplerenone, the so-called mineralocorticoid receptor antagonist, should also be avoided. If women are on a calcium channel blocker like amlodipine, this could be continued. There are lots of other calcium channel blockers like felodipine, lercanidipine. There's less data on them. I would generally say if the people are established and controlled, they're generally thought to be safe, but the data that's greatest in safety is around nifedipine and amlodipine. Doses can remain unchanged unless their blood pressure becomes lower, which sometimes happens in the first trimester. So monitoring would be important in these people. If they're on beta blockers already, the betalol tends to be preserved to bisoprolol, but both are safe, and there are many other preparations of beta blockers like sotalol and nebivolol, which have less safety data, but are used in many other cardiac conditions without issue in pregnancy. So the next bit of the NICE guidelines covers those who aren't already established on drugs. So they're developing a pregnancy hypertensive disorder. A NICE state that we should start treatment if the blood pressure is more than 140, or, and that's the important, or their diastolic is more than 90 per Sicily. And this is sort of quantified as on more than 2 occasions when they're seen more than 20 minutes apart. The target treatment blood pressure is 135/85 or below, and this is for both gestational hypertension, preeclampsia, and chronic hypertension. If women are established on treatment, how often should we be measuring their blood pressure? Nice to differentiate this between the different hypertensive disorders. So they say once or twice a week for PAH or GH, and also they should be having weekly bloods and a weekly urine dip, as well as the usual fetal monitoring, but I'm not going to talk about the fetal aspect today. For chronic hypertension, they suggest once or twice a week is also adequate. But for preeclampsia, which people are obviously more worried about, they're suggesting every 48 hours with bloods being done twice weekly. Interestingly, in those women who weren't hypertensive and in those with chronic hypertension, covered in both BUMP 1 and 2, two trials recently published in the last couple of years, there was no benefit to self-monitoring antenatally in terms of early detection over standard care or improving maternal or fetal outcomes, but there was a definite qualitative improvement in that women felt more reassured and empowered to be in control. So antenatal monitoring with home monitoring is a sensible approach. The other things that are important in the NICE guidelines, particularly as midwives are often seeing women more frequently between obstetric clinics, is the importance of making sure the LGF or the soluble FLIP-PGF test is done at the relevant time period. For those who've got PIH or chronic hypertension, to look at their risk of developing PET. And again, this is not my area at all, but obviously discussions around birth timing are very important when women have got one of these conditions. The last slide on the antenatal side of things is which drugs should be started if you are starting treatment new. So NICE recommend labetalol still first line, nifedipine second line, and methyl-dopa third line, or it could be used in addition if labetalol and nifedipine aren't controlling it. The important thing to note about methyl-dopa is that it's a pretty horrible drug in terms of its side effect profile, and it should be stopped as soon as it's possible after birth, a NICE state within 2 days. In terms of which drug to use, labetalol and nifedipine, I would tend to favour what the adult hypertension guidelines would say, and that calcium channel blockers do tend to work better in Afro-Caribbeans, and labetalol in white Caucasian. There is some data published. It's not made it into the NICE guidelines or the American guidelines as yet, which sort of tailors treatment based on some measures of women's cardiac output and peripheral vascular resistance, i.e. how much resistance is within their peripheral vascular system. But because those aren't routine tests available on the NHS, that isn't there. Some people might work in centres, for example, like George's, where Basky does tailor it based on hemodynamic measures, and I know there's a few other centres around the country doing this. Obviously, the cut-off for admitting people is important. So just to reiterate, obviously, if the BP is above 160 or 110, this is not an and, it's always an or if they've got any red flag clinically based on the symptoms they're describing, or on their bloods, or on the fetal monitoring, obviously admit them. And they need daily measurements at least when they're in. And once they're stabilized, so it's already clarifying that it's 4 times a day once they're in, daily measurements post-discharge once their BP is controlled. So if they are admitted with a BP above 160, 110, they should be going home with home monitoring. So postnatally, an area which I'm more familiar with, as it's where I focused the research for the last 5 years of my life. I'm going to start by touching on what the NICE guidelines recommend, giving a few thoughts of my own as we go, and then I'll come on to what I think is an amazing toolkit that's literally come out in the last couple of weeks from the American College of Cardiology and the American Heart Association, which I think has sort of taken forward the latest evidence from several trials around postnatal care of these women. So, postnatally, how often should we be measuring blood pressure? For gestational hypertension, the NICE guidelines suggest we should be doing it daily for the first 2 days, and then just once between day 3 and 5. And for preeclampsia, it states 4 times a day as an inpatient, as I mentioned on the previous slide, and then once daily day 3 to 5, and alternate days thereafter if it was still elevated during that period. My personal feelings is that neither of these are adequate. If you look at a meta-analysis or Cochrane review, which was done by Laura McGee over a decade ago, the systolic blood pressure doesn't peak until day 5 to 7 postnatally, and diastolic blood pressure peaks even later, out to a maximum of day 10 in some cases. And there's also a phenomenon which affects about 20% of women, which is called postpartum hypertensive pregnancy, or so-called 4th trimester preeclampsia or 4th trimester gestational hypertension, and this often comes on in that initial day 3 to 10. So if you're only monitoring out to day 3 and then alternate days, often it's picked up late and often it can be missed. So I think daily monitoring for the first 10 days for either condition is really important. When should we be starting treatment? If they weren't on treatment antenatally, so if they were on treatment antenatally, generally women are left on the medication that they're on. I personally think, again, this is the wrong approach, and we'll come on to that in the next slide. But if they're developing de novo hypertension in the postpartum period, I suggest that we start treatment at 150, 100 for both conditions. Again, I feel this is too high, and personally, I follow the adult hypertension guidelines, and if their blood pressure is persistently above 135 or 85, treatment should be started. And the rationale for this I'll come on to in a little moment when I talk about some of the trials that have come out in recent years. When to down titrate, so NICE in their NG133 guidelines suggest reducing the dose when the BP is below 130/80 and considering reducing if below 140/90. But again, I disagree. I think this reduction at 140/90 is too early. 130/80, fair enough if people are symptomatic, but otherwise I would favour what's on the ACC and HA toolkit. All of the references, by the way, that are in superscript are at the end. And I've put a link into this toolkit for you to be able to access it because it's got some fantastic slides. Important thing obviously here as well is if you are the midwife looking after this woman postnatally, is they should be seeing a GP or a specialist such as yourself at weeks 2 and weeks 6 to 8. And if they remain hypertensive at weeks 6 to 8, they should be referred into an adult hypertension service. And if you're lucky enough to work in an area with a dedicated postnatal clinic, which there are very few and far between, try and get them in. A quick touch about the diagnosis, particularly in the postpartum period, and this is a little bit where sort of NICE guidelines differ between adults and general adults, which is NG136, and NG133, which is hypertension in pregnancy. If you're seeing a general adult, they say that if the clinic BP is above 140/90, then offer home blood pressure monitoring for a week, or ambulatory blood pressure monitoring, which takes weeks and weeks to get. This is just not feasible for people who you're looking after on the postnatal ward unless you have to be guided by the clinic BPs. And as a result, it's really important that we do the clinic blood pressure as well. So just to reiterate, the advice that's given by NICE and the British Heart Foundation is that we must standardise the environment, try and provide as relaxed an environment as possible. So when the baby's screaming, probably not the best time to be doing the blood pressure. Ideally using a validated device. Automated devices validated for pregnancy. Some like the MicroLifes and the Armrons are great. Making sure that the cuff size is appropriate for the arms and make sure the arm has been measured and that you're using the right cuff size. The arm should be level with the heart, and this can be either sat, resting, or laying in the bed. Legs uncrossed, they shouldn't be talking. There is some data suggesting distraction techniques such as listening to music if you think there's a white coat element, or reading a book can help. And if the first reading's high, we normally would repeat a second and a third and average that second and third reading for the clinic BP. So one other thing to touch about when we look about starting treatment in the postnatal period, or if you're continuing treatment on, is to reiterate the diet and lifestyle advice, including a low salt diet below 3 grams a day. 5 to 8 fruit and veg has good data on lowering blood pressure by 10/5 systolic and diastolic. Exercise is very good for the heart. Doesn't particularly lower the blood pressure initially, but there's good data on yoga lowering blood pressure. So postnatal yoga is something I advocate in all my clinics. Alcohol acutely puts blood pressure up. Most people won't be drinking huge amounts in the postnatal period if they're breastfeeding or expressing. Smoking, obviously, is a no-no for many reasons, but particularly for blood pressure. And obviously contraception. When we're talking, it's important that they're not going onto the combined pill, and amazingly, you still see some GPs starting the combined pill in women who've had a hypertensive sort of pregnancy. Also important at the time we're starting treatment that we mention why we're starting this particular drug, what the potential side effects could be. Lots of people like to read the leaflets, which often scare people, so just focus on the take-home messages, and we'll go on to that in the next couple of slides. And also signpost into organisations that have done a lot of research and give a lot of support. APEC are fantastic. The British Heart Foundation have some great leaflets and links to low blood pressure diets and how to do blood pressure and what type of exercise to be doing and when. So let's have a little look at the postnatal period and how the two guidelines between general adults, which is this one, and hypertension in pregnancy differ. If you look, you'll see that they're very similar. So the adult hypertension guidelines is A and C, A being white under 55, C being over 55 or black or Caribbean, so African or Caribbean. And then if the one on their own isn't working, then you add the combination. And if that's not working, then you add in a thiazide-like diuretic. And there are further steps, but I simplified it for this talk. If we look at how this is similar to the one in pregnancy, you'll see that it still has the A and C as the mainstay. So the 55, probably not so relevant because most women are going to be below that age, if not all. So it's more to do with your ethnicity. So if you're white Caucasian, an ACE inhibitor is first line. If you're African or Caribbean, then calcium channel blocker would be first line. And there are slight refinements to which ones we would use. So for the ACE inhibitors, enalapril and captopril have the base safety data, having been used for peripartum cardiomyopathy and heart failure for many years. And nifedipine and amlodipine have got the best safety data for the calcium channel blockers. If they're not breastfeeding and they're not getting on with amlodipine, though, I personally favour felodipine and lecithiazide. They're very well tolerated and don't tend to cause the ankle swelling. If one of those isn't working, then you add them together, a bit like the other guidelines, and then instead of a D being added in, the third drug in the postnatal period generally recommended is a beta blocker, labetalol or atenolol, and NICE actually suggests avoiding thiazide-like diuretics, or ARBs like candesartan and azartan if they're breastfeeding or expressing. If they're not, you could use a D. So there'll be the rare occasion where A, C and B aren't enough. Pretty few and far between, but there are some women we have going home on 3 or 4 agents. So which drugs should we be using or would we be adding if we're seeing women and their BPs are still above 140/90 when you're seeing them, or 135/85 on home monitoring? So if guided by their electrolytes principally, and also whether they're breastfeeding or expressing. So if the potassium is below 4.5, spironolactone's got the best data at controlling blood pressure, but it does upset the tummy, causing nausea and diarrhea in about 10%, and it's contraindicated if they are breastfeeding and expressing because of its impact on the fetal renin and aldosterone axis. Not the fetal, sorry, the babies. If the potassium is above 4.5, then indapamide or a thiazide-like diuretic, but again, breastfeeding and expressing, it's contraindicated. And so if those are the cases, you've got 2 options we principally use in the UK, which are doxazocin, which is an alpha blocker. It's a very potent vasodilator, so it dilates the blood vessels and therefore drops the blood pressure. It provides very quick control, but it has to be carefully initiated, very slowly, and titrated up. If you go on too high a dose and you vasodilate, the blood pressure will plummet, and they'll feel very pre-syncopal, or worst case, even blackout. So it's important to start at 1 milligram BD and titrate slowly with careful home monitoring. Hydralazine is very good if you've got someone who's got pre-existing CKD. It was the old-fashioned treatment used for heart failure, people with renal disease. And again, it's a vasodilator that's very potent, so you start at 25 BD. And it's also used antenatally in preeclamptic emergencies and intravenous setting, as you'll probably be familiar with. So real-world practicalities, from my experience, so enalapril is first line in the NICE guidelines. I think it's a fantastic drug. There was a nice trial from Jenny Myers in Manchester suggesting some additional benefit beyond the blood pressure lowering it, albeit very small, and we're hoping to see a bigger version of that trial to see if that holds true. The practicalities of using it are that it's very, very safe in breastfeeding. Lots of obstetricians in the US are really shocked at when we took on our NICE guidelines and we started to use ACE inhibitors, and there's still a bit of inertia in it in many centres, but it is very safe. The guidelines do say to inform the neonatal intensive care or HD or PICU for completeness so they can monitor the BP in very small prem babies, but I had at least 20% of my trial of 250 women on NICU for months being born below 24 weeks, and none of them had a blood pressure issue. So important thing to know is it doesn't work instantly. The way enalapril works is it deactivates your renin-aldosterone system, or your renin-angiotensin-aldosterone system, or RAS for short. That's its principal way of working. It does have a little bit of a vasodilator effect, but the majority of its impact is driven by that RAS system impact. And it takes about 24 to 36 hours to start working. So if you're starting it and their BP is roaringly high, it's not going to work. They must have something else given, and slow immediate release nifedipine is often the best thing because it gives you great vasodilation and good control. So if you're picking up someone in the postpartum period and the BP is climbing, I would titrate it rapidly. And if it's day 1 when you're picking up the blood pressure going up, you need to use the nifedipine alongside. Once it started to work, wean the nifedipine off very quickly because that causes headaches, and then adjust the doses of enalapril guided by their readings. Once you get beyond day 10, you often see the BP coming down the other side of the mountain very quickly, and you often titrate very rapidly. So you might go from 20 BD to 10 BD over 2 days to 5 BD, and there are no concerns about upping and downing like this. It doesn't upset the kidneys. You'll see in the SPC that there's a theoretical risk of AKI, but I think if women are eating and drinking and their baseline creatinine is okay, the risk of this is incredibly low. But to dot the I's and cross the T's, if you can get a set of UNEs done, you're following the guidelines. Calcium channel blockers, so as I've said, nifedipine gives you very good control, but it's annoying for women. It requires TDS dosing, and you get on and off periods with it, which cause headaches, and it also causes BP lability. So I would suggest if you're going to use nifedipine, use a modified release prep, like nifedipine modified release 40 milligrams, and use it as a second-line agent alongside the ACE inhibitor. If you are using it first line because it's African and Caribbean, then definitely use the slow release prep and titrate it up, or use amlodipine. Often amlodipine on its own won't give good enough control in that first 10-day period, though. You need to use the ACE in there as a second line. The betalol, as I say, certainly in our centre, most people are discharged on this because it's a sort of obstetric legacy and it's what doctors, midwives are familiar with. But it is a very poor drug postnatally, and it's certainly not a drug we use in adult hypertension unless it's fifth line, because it's not particularly good at treating blood pressure. You need high doses, and you need either 3 or 4 times a day. It causes bradycardia, fatigue, and BP lability because of this dosing interval. So if I see someone that's on the betalol, I wean them off it as quickly as I possibly can, such as the regimen I've given there, and I add the enalapril and titrate up. And I use the betalol just to cover the enalapril coming in that 24 to 6 hours as it's blocking off the RAS. Methyl dopa, as we mentioned, avoid postnatally. And Dr. Anderson, we talked about before, very useful, particularly in African and Caribbean patients where you're needing something else alongside a calcium channel blocker. If the ACE inhibitor is not working, and as I say, start at 1 or 2 milligrams twice a day, probably 2 milligrams twice a day if they're above 150, 90, but if they're not, go with 1 and just titrate gradually. Very safe. You don't have to worry about the kidney or liver function. It's just about making sure you don't cause profound hypotension. Little comment about stress. This is one of my favourite slides from another talk, more relevant to sort of the role of stress in the Western world, but stress acutely puts your blood pressure up, and this is a very stressful period in women's life. They've had difficult deliveries often. They've often had to be admitted, deviating from their birth plan, and then postnatally, all sorts of blood pressure measurements, poor sleep, and stress. So we've got to do what we can to try and minimize stress, both acutely when in the hospital and after discharge. And I think that's why telemonitoring and home monitoring is great, because it allows people to take control a little bit of their own health. Certainly chronic stress makes a huge difference to your blood pressure. If you look at this population here from an indigenous tribe in the Amazon, they did a case control study of those who stayed within the Amazon and those who moved up to the southwest of USA, and tracked their BP throughout 5 decades of life. Those who stay within their native tribe have no age-related increase in blood pressure. Those who move to America, the blood pressure goes up. It's stress, not genetics. Same thing shown in a Tuscan monastery in Cortona, a nunnery. They looked at the nuns and the monks, and they tracked them throughout life over about 4 or 5 decades. And the bars in white there that say static are the nuns, where they're not stressed, staying within their monastery or nunnery. And the bars in black here, this is such an old slide that this one's faded, show an age-related increase in blood pressure of about 5 millimeters every decade, which is what we see in almost every Western country. So unfortunately, Westernized life is stressful. So this is the toolkit I mentioned earlier that was just published in the last couple of weeks by the American College of Cardiology. It's called the Postpartum Hypertension Clinic Development Toolkit. It's about 50 slides long. It's got huge amounts of information in about how you can do it, which stakeholders to involve, how you can involve primary and secondary care, different models which may work in different settings. So certainly recommend reading that. I'm just going to handpick a few slides from this which sort of reiterate the comments I made earlier about the NICE guideline thresholds being a bit too high, and also the NICE guidelines for down titration being a bit too cautious. So busy slide, but just focusing it on here. As I mentioned earlier, NICE recommend only daily monitoring up to day 3, and then alternate days, day 3 to 5. Here they recommend 1 to 2 times a day in the first 2 weeks. I would highly advocate that because of this lability you get, particularly in diastolic blood pressure beyond a week out to 10 days. I'd also agree completely with this box on the left that we should only be down titrating when their BPs are below 120/70. So I'm quite happy leaving them between 120/140 over 70 to 90, but ideally you want them in the 120/70s or very low 130/80s. So I favour this, and this is based on some recent trials, which will come on in a moment. Busy slide again, but just focusing in on the very top left box. The first line agents in America are actually almost come in a line, which is the first time in many years where we were using similar drugs. So they like nifedipine, enalapril, amlodipine, and labetalol. They actually use nifedipine first line, and I think that's because they're still cautious about enalapril in the kidneys. But I'm sure that will change in due course. And as you can see in the top right, they're very, very safe. All of these top four are safe. The other options we've touched upon, such as hydralazine and spironolactone, we don't tend to use loop diuretics over here, but they are safe, and we use them if they've got peripartum cardiomyopathy. We tend to use indapamide rather than hydrochlorothiazide over here. The toolkit also provides approaches to increasing medications in stable patients. I think that they're titrating too slow, particularly for the first 10 days, but beyond that, the table's very useful. They say if after 7 to 10 days the BP remains high, double the dose. I'd say if you're seeing consecutive readings over 2 days, they're only going to climb it if you're in that first 2-week period, so double the dose. And that, whether that's nifedipine or enalapril, particularly in that period, but beyond day 10, usually the BP comes down quite quickly. So this is still a fairly useful table beyond day 10 if it's still climbing, and it contains it for the 4 common drugs we use in the UK. So what about telemonitoring? It's now endorsed by the HA and ESC as of last Friday in the new ESC guidelines, which Richard McManus presented an update on, largely on general adults, but it also included pregnancy hypertension. So this is taken directly from the new toolkit, and it says here, remote blood pressure monitoring programs. There is robust evidence demonstrating the use of them. With clinical support, they can significantly lower blood pressure. And just to quote my own trial, the POP-HG trial mentioned in here was the trial that sort of set the bar in it, showing the benefit of remote BP monitoring and adjusting medications remotely. Whilst doing that in a trial setting is hard in the real world, as long as you're giving women a monitor and as long as you've got a way of contacting them, it can still be done. What did the POP-HG trial actually show, if you haven't been familiar with the papers? So we took just over 220 women, randomized them to self-management with a smartphone app and a wireless monitor or usual care via GP and midwives, followed their BPs at week 1, week 6 and 9 months, and at 9 months their blood pressure was over 6 millimeters lower diastolic and 7 meters systolic, and it had been lower throughout, and the separation occurs from as early as week 1. And this holds true for both clinic and ambulatory blood pressure monitoring. And when you look at their hearts on echo and cardiac MR, you also see very beneficial remodeling, which we think will hold longer term benefits for their cardiovascular health, but we have to follow these women up longer term to show that. And all of these fancy arrows here are just showing improvements in pump function, the thickness of the walls, left atrial volumes, and relaxation of the heart, which are these medial E's and E primes. But don't focus too much on that. It's beyond the scope of today. The important thing that POP-HG also showed was a huge reduction in BP-related postnatal readmissions. This is obviously a cost burden for the NHS. It's also super stressful, and we remember earlier how important stress is when we're trying to control blood pressure, as well as the psychosocial impact on the partner who may not be with mum and the other children who may having to stay at home. So it was a 72.5% relative risk reduction. You only need to treat 5 women with self-management to avoid 1 postnatal readmission. There are other advantages in telemonitoring. So several trials have shown that it's safe and effective, not just POP, with 8-fold fewer hypertension-related admissions in a paper by Karen Hopper in 2020. It also shows huge impact on reducing ethnic disparities in the US. Soirinel in the coronavirus pandemic used home BP monitoring and showed that 90% compliance. The standard of care in the NHS is only 1 in 10 women gets a postnatal blood pressure measurement. That's absolutely abysmal. So, this has a huge ability to revolutionise care in the USA. It's also well liked by women. There's several studies. Alex Cairns in Oxford followed up her SNAP trial, which preceded POP, and showed that it was very well liked, and there's several other trials by other groups which have shown that it's well liked. What else is around that may help going forward, just to close out the last couple of minutes, there was a trial published in South America called the 4BP trial that suggested actually adding frusemide alongside placebo and the other hypertensives actually reduced their persistent elevation of BP. That needs to be picked up in a larger trial and looked at. As I mentioned, Jenny Marr's trial from Manchester showed that this appears to be an additional benefit to ACE inhibitor. So these women were on the usual antihypertensives, i.e. calcium channel blocker or orbital, and they all got an enalapril as well, postnatally, and they had better remodeling of their echo on their echoes, as well as having improved diastolic blood pressure at the end of the trial at 6 months. So what's coming next? Richard McManus is going to take the work from POP forward and look at a multi-center trial of the self-monitoring and self-management in 31 centers and more than 2,000 women. That's going to start very soon. And Pickup 2 is hopefully going to get funded soon, and is going to be hopefully a validation study of enalapril and its role in the cardiovascular remodeling. That's 30 minutes up, so I'm just going to cover with some quick conclusions. Pregnancy hypertension is associated with a significant increase in the risk of cardiovascular disease, not just hypertension, but valvular disease and ischemic heart disease. The postpartum period appears to relate to your long-term risk, and observational data shows that if your BP is high in these first few weeks, it's high at 6 months, and your BP at 6 months needs to predict your blood pressure 10 years later. There's a very limited evidence base for blood pressure management in the peri and postpartum, and most of the new NICE guidelines were adapted for NG136, and they did a very good job. I don't think they go far enough, and I think the new toolkit from the AHA gives better guidance on how we should be measuring BP, when we should be down titrating. And we know now from POP-HG and other trials that if we can modify the blood pressure and improve the blood pressure control in the so-called puerperium in this first 6 weeks after birth, we can improve short and medium-term blood pressure and their cardiovascular remodeling. And this ultimately may lead to improved long-term cardiovascular risk. I hope you've enjoyed the talk, and I'm hoping to be able to join you for questions. My email, if you did want to contact me, is jamie.kitt@cardiov, that's cardiov.ox.ac.uk, or it's jamie.kitt@royalberkshire.nhs.uk. I hope you enjoy the rest of your day.